all these buttons.
There you go.
Kevin, how are you?
I'm doing good.
There
Hey,
you
I thought
are.
I'm okay with technology, but I guess I'm not.
Well, usually Craig sent you to the wrong room to see how you can react. He likes doing that to me too.
Yeah. I sent you to the wrong waiting room.
I see.
Just kidding. Anyway, I want to just really thank you for coming on board here. We've got a panel here, and everybody, my name's Craig Todd. And Kevin, I just want to introduce you to Rachel Breeding, and she's the vice president of Med Network. And I'm going to kind of step out and just be quiet, and the panel will take over from here. So this is Rachel Breeding, vice president of Med Network.
Thanks, Craig. Hi, Dr. Vo. Again, my name is Rachel Breeding, and I'm the vice president of Med Network. And to my right here, we have Corey Lee. He is our CEO.
Great. Well, thank you for your time.
Brian Weaver is our VP of Operations, and Brian Weaver is our VP of Business Development, and Roy Gilbert is our VP of Operations. And then Bob Sears, he is our Chief Optimization Officer. So Dr. Vo, could you just begin by giving us an introduction about yourself and Athena Family Medicine, and then I'll have Brian Weaver take it from there.
Yeah, so I do family medicine. I've been in Rowlett here probably 6 years now, and been in practice for the last eight years. And basically just family medicine. So we see all ages here, but it seems like the last 4 or 5 years, I kind of attract more or less of the senior patients, so more or less Medicare patients here. But we do see commercial insurance as well. But it looks like the bulk of my patients are, like, I would say probably 60, 65 patients are Medicare patients. So we do anywhere from, it's growing tremendously after, the COVID, the last few months here that I've seen more patients now. I guess people are, feeling the need to kind of come back out to see us now more. But yeah, I'm not sure if you guys, have any question about family medicine, but, I do a little of everything here. And I try to keep patients in-house. Unless I cannot manage them here, then of course we'll refer them out, but we try my best to kind of do everything I could here. And so far I'm the only doctor here. So hopefully, in the next few months or so, with the volume we're growing, and I'm thinking of just kind of get like a nurse practitioner or PA on board to help me out. But for now, I'm the only provider here, and the rest are really helpers, medical assistants.
Perfect. So, Dr. Vo, my name is Brian Weaver. I just want to say thanks for taking the time today. If you wouldn't mind, I just like to start my calls with this: is why do you think we're here today, and what interested you in taking this call?
Well, at one point I talked to Craig there that, with the amount of work I do here, with the amount of patients, it seems like, I'm not compensated for as much as I'm doing with the time spent with patients as compared with my peers who are more specialized in medicine. Okay. And then Craig, one day he saw me and said, hey, I got this, this group here has been working on these kind of tests here that my patients can benefit. At the same time, I can get more revenues to the clinic.
Awesome. Perfect. I probably couldn't have asked for you to have a better understanding of what we do. But let me tell you about the clinical side, and then we'll go into the business side, if that's okay. So the initiative we're talking about today is a combination ABI, ANS, and pseudomotor testing. It's a testing service. And I say testing service because it's packaged as a service. We provide the testing equipment. We provide the fully trained, salaried MA. I like to say we provide everything from the testing device, which is somewhere in the range of $70,000, down to the Clorox wipes we use to clean off the the blood pressure cuffs.
Mhm.
So this is meant to be a complete zero startup cost for you when you start, when we get started. So as you know, ABI, ankle brachial, ANS, pseudomotor, what we do is it's a 20-minute test. The MA can work with you in a bunch of different workflows to perform the test. Rachel, could you pull up the intake form?
Yes, give me.
We use an 11 question intake form to demonstrate medical necessity. And I'm sure as you see this, you can, any number of patients you've seen in the near past would have at least one yes to these questions on the intake form.
Dr. Vo, by the way, 'cause
Let's
it's hard
zoom
to
that
always
in
see
a
on your
little bit,
phone,
take a
but
look
you can
closer.
pinch and zoom on your phone.
I can
if
do
that
that.
helps
Okay. Yes, sir. Great, great.
Thanks, Corey.
So Dr. Vu,
Mhm.
how, you have your two main clinics across the lake from each other. Do you, and obviously you can't be in two places at once and you're the only doctor right now.
Mhm, mhm.
So do your nurses see patients on the off days? I would imagine you're 2 and 1, 2 or 3.
No, that was the initial goal, is to eventually have some mid-level providers like an MP or PA sees the other locations when I'm not there. But at the moment, we are in the process of basically building up the 2 locations. So far, I have no helpers at this moment. So I'm the only provider at this time. So when I'm at one location, the other location is basically kind of empty.
Just making
yeah,
appointments.
yeah, making appointments there. Yes, sir.
That's great, because we can use pulse for pulse to fill up the other
We can-
location.
We can
Why you're-
have that empty office while you're in the other office making money for you.
Absolutely, absolutely.
Correct.
Yes, yes.
So let me just finish kind of giving you my intro of what we're doing, if you don't mind. So we provide workflow support for you.
Mhm.
The MA will help with that. We also provide clinical support in that we have a 1-800 number that when you see tests, if there's anything that's unclear or you have questions about anything, you can call a provider and you can discuss the clinical results. And then we also can provide the billing for you if you choose, or we can give you a billing liaison to make sure all the bills are being dropped correctly and all the adjudication is done correctly. So the test itself generates about a 38 to 40 page document that you will never want to see. There's a 2-page results and recommendation report that will come to you, and it looks similar to this. We use, a typical stoplight colors. Red, obviously, it's abnormal, there's an issue. Green, there's no issues and it's within normal range. And yellow is something to keep an eye on. And as you can see, I don't know if you can see on your phone, there are recommendations. We can tailor make those recommendations to read similar to what you would like your patients to see. So while we do have some that are already created, you might have, like, for example, I saw that you have a weight loss portion of your practice. We can tailor make some of these recommendations to drive business to your recommendation, to what your weight loss plan, and to what, depending on some of these on some of the results. So
yeah, I did have a copy of from Craig's. I guess he ran his own test here. So now a few of these here that I thought is very interesting. The pseudomotor system, that's something I'm not familiar with. In my lineup as far as for family medicine here. Of course, with cardiovascular.
So the question I have is,
ABI,
Craig going to be around for a while? Could you have Craig's test there?
just to make sure. Now, tell me about, as far as for the approval within the medical, as far as for field on this area, with as far as for what I'm trying to get at, as far as for the FDA approved and with insurance, what are their take on this, and how long have you guys been doing this? I just want to make sure, when patient asks and if I were to introduce patients to, run this test here, and they've never, met your staff, and it's like, who are these people and things? What would I tell them?
Sure. Well, Pulse for Pulse itself has been running tests as their company 5 years. They're fully approved by the FDA. We're being reimbursed by Medicare, Medicaid, and all major payers. So the fact that we could clear that bar for CMS to be paid by Medicare, it's obviously tried and true medicine. We are undergoing 3 different studies, 2 at Harvard, 2 at Yale, and 1 at Harvard right now about the testing accuracy and things itself. We can bury you in white papers if you'd like, in terms of testing, talking about the testing. And as you know, ABI, pseudomotor, and ANS, none of this is new stuff. What really is new about it is the way our CMO has developed this algorithm in the comparative database. He uses that algorithm to take the norms and the data points that are generated by the testing, compares it to a comparative database of about 15 years worth of patients. This testing is done in real time, so the algorithm is gaining greater clarity as we go, and the results are becoming more and more dialed in, so that we feel confident saying we can predict disease states 5 to 10 years before onset of symptoms.
Gotcha.
So with talking about some of your patients, as you said, for the past 4 or 5 years, you're starting to see some patients that are a little bit older. I feel like this could be a great benefit to your patients. We're going to get you great clinical data. You'll be able to improve the outcomes you have for your patients. And, I feel like we check the box. We'll definitely check the box in terms of the financial piece, and we can get into that a little bit as we go. Roy, do you remember the number in Texas, in Dallas?
It's for Medicare. The allowable for Medicare in Dallas is $373, something like that, maybe $1 off. Medicaid, which I see that you have applied for, but aren't seeing Medicaid patients yet, right?
Correct. It's
That's
just the
about
area that
$100.
we're in. Just the
about
area we're in. It's very hard to see them.
Yeah, it's about
We
$100
try, but it's just seeing them. It's just one of those that it's very hard to take care of them if there's no management I need to do for them or referral. No one really around here. All the specialists are not accepting them.
Yeah, well, and the area of Dallas that your clinics are in are so fast growing with all kinds of population. I mean, it's huge. And but one of the things that I wanted to bring up was you have Craig did a test, you have that in front of you, and that's really his baseline. So this is a serial test, kind of like an A1C with diabetic. You bring them back every 3 months. So Craig has a test, and it's like, Craig, you're a walking train wreck. You need to do this, and we're going to prescribe such and such, and we're going to bring you back in 90 days, and I'm going to see how compliant you are. We're going to test you again and see where you are. And so Medicare and the other insurance companies will pay multiple times a year for this test. Now you have a follow-up visit also to go over the test, obviously, with your patients. The test that you're looking at, the report that you're looking at, kind of like anything else, is the more you do them, the more comfortable you are looking at the data. And what Brian said is that we can have you doctor to doctor have a conversation to go over and say, I have a question about this. I have a question about this. You go over this test a couple of times with one of our docs in support. And, after you run 10, 15 of these tests, the first 10, 15 of these tests, you'll be like, oh, I know exactly what I'm looking at now. So.
And you did have some questions about the pseudomotor portion of the testing. I'd be happy to
Yes, that's kind of
facilitate it.
new to me there to see what we really are interested in looking at there. What kind of, Basically, it says autonomic there, but what else does that tell you as far as information about a patient?
Great question. And when we get into the clinical portion, I get into the deep end of the pool way too quickly. So the best thing that what I would like to do is set up a provider to provider phone call for you, and they'll go through all of those clinical questions that you have. Just because if I give you some information, you're going to have another question, and I'm not going to have the answer for you. So I'd like to have a clinical let's set up a clinical call for you to really get in depth and make sure that you're really comfortable with the results and the data that you'll be getting.
Yeah. Okay? Sounds fair. Yeah.
Okay. Yeah. So if you know, so we started to talk a little bit about the financial piece. So Roy gave you the number of $373 per test revenue that you typically see. That's the testing piece. The private insurance will be slightly higher. So somewhere say between $373 and $385. Then Roy talked about the follow-up revenue that you'll generate. So basically, you know, the good thing about this is you're not only getting new clinical data and getting better patient outcomes, you're now collecting new monies that you're not running tests right now to generate revenue for your practice. And I know that was one of your concerns. You're not seeing the revenue that's of some of your colleagues are. So this could be a good way to help you your bottom line, running clinically relevant tests that are going to help your patients.
And it'll help you keep your patients.
Correct.
So you'll have a much better feel for when you need to refer somebody out and when you can keep them without questioning your second guessing your judgment, which you probably don't do anyway because you're seeing way too many patients a day. Are you seeing 25 a day?
Not quite there yet. We're hitting around 20 right now, about 18 to 20.
Okay.
But that's a mixed picture of basically everyone. Kids, mid-age and all the way to up to 90s.
You need an FNP or PA.
Pretty soon.
Yeah.
Well, now, if you wouldn't mind, Dr. Vo, tell me a little bit about your weight loss portion of your practice.
So that is something I've been just doing recently, the past year or so, seeing family medicine patients on the overweight and obese side that leads to all this metabolic syndrome. We talk about obesity leading to diabetes, cholesterol, blood pressures, all those things. They're all related to weight.
Sure,
so
of course.
When I counsel them really about, nutrition and physical activity, but to what extent, to what level they can do on their own, that's questionable. And then, for the one that really try their best to do it for 6 months to a year and hit a star that they can improve anymore, then that's when I step in. I step in with prescription weight loss medication. That's going to combine with what they've already been doing. And that has been a really, a boost for them to get over that hump that they try with nutrition and diet and exercise. And so basically for me to step in at that point is really prescription medication.
And the great thing about that, and we have great success in placing this in programs like that, whether it be wellness or nutritional or weight loss, because while you're doing that, as Roy talked about, to build on that, you can get the first time you see someone in that program, you can get their baseline measurements. And you can also, so you can give not only data what on the scale or the way their clothes fit, but you can actually give them clinical data that says, look, all of these values are improving. Oh, so your general health is improving along with the way you feel and the way you look. So, that's something that I think, this would probably be another box we check for you in terms of, how we can apply this in your practice. And, our MA will help you with doing that. And, we didn't really go into the workflow part, but I'd like to, if you don't mind, we can deploy, even in between your two practices, different workflows that works around the way you see your patients. So, we make this very We are a physician-owned, physician-operated company, so that we make this very easy for the practice to adopt. So we take all of the onus of performing this testing on us, doing the billing, doing the workflow. So it's not something that will interfere in your day. So while you're seeing your 18 to 20 patients, we can be running, 6, 8, 10 tests per day, buttressing your bottom line, getting you great clinical data. And it's all being run in conjunction. It's really basically no effort on your part.
Mhm.
Okay.
So I want to go two things, Dr. Vu. One is about the weight loss. When your patients plateau
Mhm.
and they start losing their steam, when you have to step in,
Yep.
what this will do, I think, and what we've seen is that as their values may be getting better, even though their weight loss isn't relatively going down at the same time,
Mhm.
they're becoming healthier.
Yeah.
And now you can actually show them that. Even though, well, they lost 10 pounds and they're plateauing, but
Mhm.
look at these values. And it's a real nice way to have a conversation about getting them to the next level and being more compliant with the program that you put them on. with your
Mhm.
plan.
Yep. Absolutely.
So I just wanted to go back to that because I think that's in the weight loss area, I think that's a really good starter. The other thing is sleep apnea. You look at at Medicare patients and I spent a lot of time in Texas, And one of the things about Texas and where I live in North Carolina is about the same, is the older you get, the less you want to go to the doctor, but the more you need to.
Mhm.
And the more information you can give folks nowadays, I think the better. And what I was actually coming back to my train of thought, which is this test is done in conjunction with an office visit. So there's no extra copay or co-insurance or anything like that. Whatever they are paying for their copay for the office visit, this test goes right along with that and is tied to that in the billing process. Okay, so there's no
And this would
extra
not
out-of-pocket
be
for the patient.
charged or billed with as far as I guess the question is that would the patient seize the amount that's billed to the insurance, or would they be coming out from their pocket in any portion at all for this test?
No, unless they haven't met their deductibles, unless you got somebody with a $4,000 deductible, doesn't matter what they do, they're going to be paying out of pocket. But for your Medicare population, the chances are most of them are in a PPO or have a secondary, or I also saw you took the old Champus, but you take VA.
Yes.
And VA pays us as well. So and it's all tied with the office visit. It's the allowable, minus the discount. And the patients normally do not come out of pocket unless, like we said, there are times when patients don't meet their deductibles. And that.
If I can interrupt, Roy.
Sure,
Dr. Vo, one of the things that Pulse for Pulse will offer too is periodic profitability calls with you. So you'll see all the insurances, what the reimbursements look like. They go over individual patients' tests that have been run. So you'll have a really good idea of what the snapshot of your practice looks like from an insurance Medicare point of view. Okay. So, I mean, this is not one of those things we kind of dump the machine, we'll see you later. This is a very collaborative effort, and Pulse for Pulse will offer you a ton of support all the way through. what, like I said, Dr. Phil Majaluzzo is our CMO, founded the company. This is meant to help doctors like you, smaller doctors, smaller practices, have greater profitability, get better data, have better patient outcomes. And, a lot of the things that you said, I feel like you're probably where Dr. Phil was when he started this. You guys have a lot of the same goals, a lot of the same needs, and looking for the same thing.
Brian, could you go through workflows a little bit as well, and how this could potentially some different options, or what?
Oh yeah,
how that
I mean, we can room patient. We can the MA can room the patient before they see you while they're in the reception area. They can be seen, like Roy described. For example, if you're working at one office, we can schedule a whole day of testing at the other office to keep that office busy, and then they come back for follow-ups. Or they can be seen after you see the patient, you refer them in, and then they come back for their follow-up. Which, whatever way whichever way you prefer. And we have some days that the doctors decide they want to do one workflow and they communicate that to the MA. It's very user defined. So you can work out. We have one practice close here in North Carolina that they have 3 providers, and all 3 of them use a different workflow, and then may just adapt depending on what patient is coming in to see a doctor.
Sure.
So,
And then as far as for the test per patient, approximate time per patient for the
20
test
minutes.
is
About 20
okay.
minutes, 15 to 20 minutes. Yeah.
Gotcha. Okay. Any
Completely
preparations
non-invasive.
on their part on the patients? Do they need to do anything on their part, or you
Other
show
than
up?
taking off their shoes and socks, no.
Gotcha. Okay.
Yeah, I mean, that's all. The only thing we really ask of you, Dr. Bo, is to give us a little room to test. Rachel, can you pull up the picture of the machine? It's about a 5x5 area. It's basically a laptop on a crash cart, and to refer patients. That's all we ask from. That's what the machine looks like. All we need is room on one side where the glass plates are for the patient to sit down, and for the MA to work. That's it.
And all those wiring is just like the EKG machine wires.
Yeah, there's some there's electrodes there for the ANS portion, and the blood pressure cuffs for the ABI, and those 2 glass plates are the sweat testing, the pseudomotor.
And it is a 3-lead EKG as well.
They can go up to a 12 too.
Right, which is for the new machines that are coming out will be up to a full 12-lead EKG at the same time.
Great.
Any other questions?
No, not at this moment. I think it's a great idea. If whenever we're not using one locations, then we can basically schedule the other location for testing. So I think that will work out well. Yeah, I think the only thing I really want to make sure, because these are the patients that we will touch upon regarding to deductible and things like that. Is there a way to find out before doing the test to make sure they met their deductible before we do the test? Because I really don't want them to come out anything from the pocket at all.
I mean, absolutely, they can do prior authorizations.
Well, it's really not.
I mean, once again, that just has to be communicated to the MA.
Yeah, it's really not prior auth. It's just eligibility.
Oh, sorry.
Yeah.
So it's an eligibility. There's no Medicare and the Blues and United Healthcare.
Yeah.
And they don't require any prior auth for this test. Okay. So basically what you're talking about is eligibility and deductible. And
Gotcha.
yeah, that can all get done.
And let me reiterate one thing, Dr. Bo, if you don't mind. This is meant to be a turnkey, no cost upfront solution. So the way that looks is, from the first day we start doing testing, from 40 to 5 days later is when you will receive your first invoice. So ideally, during that time you're running tests, all the money, all the reimbursements are coming back into your bank account. We send you a bill for a portion of that. You do the revenue split on that, on the reimbursement. So this is meant to be a zero out of your pocket cost upfront. So you're just doing a rev split after the money starts to come in.
It's a positive cash flow from the first day.
Correct.
So briefly break down for me. So if I were to be at one locations, basically seeing my other patients, and then we schedule you and your staff at the other the different locations they're running the test.
Mhm.
And then I will have the patient come back to see me as a visit to go over the test with them.
Correct.
Okay. And then how with, as far as reimbursement, I know for the visit, that's a clinic visit, that's routine for us.
Right.
Now, will our clinic benefit from the test revenue?
Oh, yeah. Yeah, you're not, the office visit, the
Mhm.
established patient office visit is icing on the cake. Okay? You will probably see somewhere in the neighborhood of $125 to $150 bottom line profit per test.
The test, gotcha. Okay.
So this is a 6-figure bottom line revenue program annually. Over
And
6.
each patient can be tested up to every 3 months.
Every 3 months, 4 times per year.
Right.
Mhm. Now, is there like a criteria to show if the initial test has to be abnormal for us to continue testing them
No.
every 3 months afterwards?
No, absolutely not. Okay, all they have to do is answer yes that first time to that questionnaire, to one of those
Mhm.
questions. And that denotes medical necessity all the way through the rest of the process, which could be years and years and years.
Mhm, gotcha.
So no, you do not have to show any abnormal. And listen, I'm on Medicare. I don't care how healthy I am, something's coming up abnormal.
Mhm.
With every blood test, with
Yeah.
everything I do, there's something abnormal. So, but no, you do not have to show an abnormal value on the test
Mhm.
to order another test.
Gotcha.
Anything else?
No, I think that's pretty much yeah for now.
Okay. So if I'd like to propose kind of some next steps to you, if that's okay.
Yes, sir.
I'll have Rachel send you some information, kind of summarize what we talked about today. What we'll ask is a new practice submission form be filled out.
Mhm.
Basically, we'll ask you a little bit of information about your practice, what your payer mix looks like, how many patients. I've got a lot of it, but if you could fill that out for us to the best, or if you could have your office manager, whoever, to the best of your ability. What we'd like to do is give you a pro forma, so you can see what this would look like to your bottom line down the road.
Mhm.
We'll do another call. We'll go over the pro forma, so you get an idea of what that looks like. I know you said you have some questions about the pseudomotor testing. So during that time, I'll set up a provider call for you.
Now,
So you can talk-
preferably, to have someone on the medical side, clinical
Yeah.
side, go basically from page 1 to all the way to the last page briefly, as far as,
Sure.
because I would like to be able to sit down with my patients, go over with them.
Absolutely.
That's no problem at all.
Mhm.
I'll get that. We'll get that scheduled. So while you're filling out that new practice submission form, I'll be working on that. Rachel will reach out for some times and dates that work for you. I'll match you up with one of our providers. And then after we go through that pro forma, you can tell us how you'd like to proceed.
Sounds good.
Sounds good?
Yes,
Awesome.
sir.
All right. So Rachel will send that information out to you shortly. And just if you could, like I said, fill out that new practice submission form, and then we'll get back with you. If you could also suggest some dates that'll work with you, I'll match them up with a provider on our end, and we'll be good to go.
I think
Okay.
for me, most afternoons like this, it'll be just fine, except Thursdays.
Okay. Great. I got that
Rachel,
note
mark
down
that
too.
down.
Okay, I got it. Perfect. All right. Corey, Rachel, Craig,
Well,
anybody
that's
have
good.
anything else?
We have action steps. That's perfect.
Excellent.
I'll make sure that information is sent out, and I'll include it'll be like a DocuSign agreement. I guess it's not an agreement, but the new practice submission form, just to make it a little easier to fill out. It's just online. And then once you fill it out, it is password protected. So all that information is of course private just to you. And then so we can look at the numbers. So
Yeah.
I'll send that over to you.
And there's no obligation with that new practice submission.
No, none.
Dr. Wu. It's just,
Nope.
it's just so we could generate a pro forma and get a little information about open, close, which days you're at what practice, so on and so forth.
Mhm.
Yeah, I've
Absolutely.
got obligation to nothing. After you do that provider call, if you want to go forward, we'll get you an agreement and we'll get a go forward plan.
All right.
All right.
Great meeting you.
Absolutely. Well, thank you.
very
I
much,
appreciate
Dr.
all
Wu.
your time
Appreciate it
today.
very much. Nice meeting
Thanks,
you.
Dr. Wu.
Thank you,
Thanks,
Kevin.
guys.
All
Talk
right.
soon.